Welcome to class. We're happy to have you. Welcome, welcome. Welcome. Please kindly tell us your name and where you are joining us from. Please tell us your name in the comment section and where you are joining from. Kindly tell us your name and where you are joining from. Welcome. Please, can you hear me everywhere? Can you hear me? Am I audible? Thank you. Please, am I audible at your end? Can you hear me? Can you hear me? Am I audible? Please kindly reply in the chat if you could hear us. Our invited lecturer will soon join us in no time. But let me know while we're waiting for him if you can hear me. Oh, thank you. That's very beautiful. Thank you. Welcome to class. We're happy to have you. It's our pleasure to have you. Tonight we'll be having CPR algorithm, adult, child, sudden unconsciousness. What should be done first? What should be done later? I'm also here to learn from the experts, but is currently yet to join the call. So I'm also here to learn from the experts, and so we'll all be here together as we learn. Please let me look for people on the WhatsApp. A few minutes, please. Okay, so while we're waiting for him, let's discuss. What do you know about CPR? I will be willing to read our charts. What do you know about CPR? What have you heard about it? When a patient suddenly become unconscious, what do you think you should do first? So I want to read our comments in the chat. Sudden unconsciousness, what to do first? I'm sure you can still hear me. Can you still hear me? So sudden unconsciousness, what do you think you should do first? Let's start from there. I await our responses. Okay, so sudden unconsciousness, what do you think you should do first? For the patient, maybe you are talking together and you stop responding, or you are behind and you are looking at that person. The next thing you see is the person is on the floor. What should you do first? I cannot see our response. So thank you. You can hear me. Thank you for your responses. But when somebody suddenly become unresponsive, what should you do first? Check vitals, especially blood pressure. Okay, we're talking about what to do first, ma. Thank you for your input. So others, what should you do first? Your patients, maybe you are even talking and the next thing you see is that this patient cannot answer me again. What should you do first? What should you do first? This is NCLEX. So assess breathing. Thank you, man. No catering. You are talking, you suddenly see that this patient cannot respond again. What should you do first? Please, if you are in the class, kindly respond. And you can write, you can type in shorthand. Don't forget. A patient you have been talking to suddenly become unresponsive. What should you do first? Check for pulse. That's nice. Thank you. Thank you. So in what other situation, especially ECG, should you check for pulse? In what other situation, especially the ECG, should you first check for pulse? Who remembers? Or who can tell us? Check if breathing, then what? Then pause, okay? Call or shake the person. That is the correct option. You actually want to confirm that unconsciousness. So the correct option is to first call or shake the person. So in the process of shaking, it can be sternal rub, something like this. This is sternal rub. I hope you can see me. This is sternal rub. You can do sternal rub. You can do shoulder shrug, something like this. Then you can call the name. That's the first thing you want to do, to be sure that this is truly unconsciousness. You know, not that the patient is dramatizing. It's actually unconscious. So those are things you want to do first. Paying attention to vital signs. So, okay, we'll do all those. But the first thing is to ascertain the unconsciousness. We're going to do all those, but the first thing is what? Ascertain the unconsciousness. Be sure the patient is actually not conscious. You will still do CPR, you check vital signs, you check blood pressure, you call for help. But the first thing is ascertain that the patient is unconscious. And in the course of ascertaining that the patient is unconscious, in the course of being certain that the patient is unconscious, that is when you will now need to call the name, Mrs. Bola, Miss B. You call the name. The option of calling the name will be correct. The option of sternal rub, I've just shown us sternal rub. We do this a lot in the hospital. It is called sternal rub. The option of sternal rub will be correct. The option of shoulder shrugging, it will also be correct. Okay? It is after then you now begin to call for help. You don't want to raise false alarm. You don't want to start calling for help when the patient is actually able to help him or herself. Maybe this patient is not even unconscious and you are trying to call for help. No, you wouldn't want to do that. So you want to call for help when you are sure that you need help, not raising false alarm. I hope you understand. So that's the next thing. You call for help. Okay, welcome with me to the stage. Our teacher for tonight, our lecturer, is my brother from the north. His name is Mr. Mokhtar Salisi. He's a registered nurse Nigeria, USRN, registered critical care nursing. He's been a BLS instructor since 2017. That's why I said I'm also here to learn. He's been doing this duly licensed by American Heart Association, and he's been in nursing profession for 20 years. He currently lectures at Aminu Kano University and their School of Nursing. So we have a big fish in the house. Please, in your comments, kindly welcome Mr. Salisu Mokhtar to the stage. Please welcome him, welcome him, welcome him. Mr. Salisu, you're welcome. And keep your note and jotter. One of the main reasons why we make it YouTube is so that you can see the pressing, you can see what to do. So he has his gadgets there. I think the network has logged him out again. So he has his gadget here. He has his gadgets right here with him. So to show us, I think he said he's having the problem. To show us what to do. Okay. I've resent a link to him. Please, few minutes, he will join us now. Thank you. Thank you. We're happy to have you live too. He will rejoin in a few minutes, please. Okay, while I'm still waiting for him to rejoin, I can continue now. So let me take the delegation aspect. Who can do CPR? RN, UAP, LPN, who can do CPR? Who can press that chest? Who can do 1, 2, 3, 4, 5? Doctor, 1, 2, 3, 4, 5. Doctor, 1. You know that thing now. Who can do it? Thank you. Everyone subscribe to our channel. I hope you love this. So very soon we are bringing our classes to the YouTube. So everyone subscribe. So delegation, who can do who can do CPR? Who should do CPR? LPN, UAP, RN, ACP. I'm expecting your responses. Who should do CPR? Anybody can do it if you are trained to do it. Okay. UAP can also do CPR. Are you sure? Because if you see it in your option, what can you safely delegate to a UAP? Do you want to deliberate CPR to a UAP? Oh, okay. Are we agreeing with that? Nurse Adishola said yes. Nurse Princess said yes. Oh, I see my past NCLEX passers. I'm happy to have you. Nurse Stella is on the line. Nurse Olufunke is on the line. God bless you. Everybody can do CPR. Even if you are not working in the hospital, you can do what? CPR. You can do CPR. Okay? It's expected that that's the minimum qualification to get job in the hospital, especially in the Western world. Okay, so you must know how to do that CPR. Okay, now, so what's the depth? If you are doing CPR, what depth should you go? How deep should you go to ensure that you are having effective CPR? Like, you know, the CPR is a situation whereby you are pressing, you are trying to compress the heart in order to ensure the return of spontaneous breathing. Okay, ROSC. When you see them writing ROSC, that is what it means. So return of spontaneous circulation. That's, I'm sure you've seen it many times. ROSC. You see doctors saying, please, I'm seeing people writing RN. Everybody can do CPR. So in your delegation question, if they say that what delegation is appropriate, you know, UAP made to do CPR is very appropriate. Everybody can do CPR. Okay, no. Okay, now. So what? So when they are trying to say, you will see doctors saying, patient was called to have stopped breathing, all resuscitative efforts prove abortive because there is no ROSC. ROSC means return of spontaneous circulation. So when there is no ROSC, then the patient is what? Confirmed dead. So in order to ensure that there is return of spontaneous circulation, your CPR must get to a particular depth. What depth are you looking at? Oh yeah, your responses in our comments. I can't find our invited speaker online again. I don't know what happened. Even his chat is not responding. Oh yeah. What depth should you go? Are we responding? And I didn't have mannequin at home. But if it's not coming again, I will try my best. Where are you? You don't understand what I'm asking. What depth should you go? 5 to 6. 5 to 6 what, ma? 5 to 6 what, not Monique? 2 to 3 inches, okay? 2 to 3 inches, 2.5, 5 to 6. This is interesting. Thank you all. Thank you. I want more responses, please. I want more responses. Thank you. These are beautiful. Now, what is most important is the center where you place your hand. Very important. The depth at which you go. Very important. Knowing that you should start compression ABC is common, airway, breathing, and circulation. But in this situation, you don't use ABC, you use CAB. In this situation, it's not ABC, but CAB. The CAB means compression, airway, and breathing. In an unconscious patient, it is compression, airway, and breathing. It's online, I can't see you. I can't see you here. What's happening? It's showing me that he's online, but I'm not seeing him. It's the same. So in this situation, it is what? CAB, not ABC. Do you understand? You know that we all know that when you are prioritizing, you go with ABC, airway, breathing, and circulation. But for this problem of unconsciousness, you go with CAB, compression, airway, and breathing. Thank God. Welcome, sir. We're happy to have you. Welcome. I think his network is really bad. It's out again. Okay, he's there. I don't know why I can't put him on stage for his ear. I think it's his network. Try. So in that situation, we do is gone again. His network must really be bad. So in that situation, we do what? Compression. So let me talk to us first about compression. One, compression depth is anything above 2 inches. 2 to 2.5 inches. And in children, you use 1.5. In children, you use 1.5. Adult is 2 to 2.5 inches, meaning that, you know, what you do, no, it has to be very deep. He's trying to join, but I really can't see what's happening here. So it has to be what? It has to be very deep. It has to be very deep. Otherwise, the heart will not have opportunity for recoiling. You know that word recoiling. So you do, you understand? You know, in the hospital, no, even you. Okay, thank God, so I can add it. So welcome, sir. Can you hear us now? Hello, are you there? So even you that you are doing it, you know, you in the hospital, it's supposed to be. You can see that strength because that's the strength you will put that you will attain that depth. If you don't put in that, it's on stage. Okay. If you don't put in that strength, you will not attain that, you know, that 2 to 2.5 inches. Is very, very important. If it is too slow, what will happen is the perfusion will not be adequate. If if it's not too deep like that, what will happen is that the heart will not have enough pressure to recoil. Do you understand? Now, there is a rate. I've just told us about the depth. I've just told us about the depth. And there's also compression rates. Is out again. There's also compression rates. The depth is that 2 to 2.5. And you want to do that so that the heart will have chance to recoil before each before another compression. And please remember, it's not time to now lean on the patient. Please don't lean on the patient. That's not the right time. The fact that you need to make it deep does not give you license to now lean on the patient. No, please, let's correct that. The second one is compression rates. Why depth is different in children and adults? I've told us children is 1.5, adults is 2 to 2.5. For rates, is the same thing, 100 to 120 compression per minute. For both adults and the children, the compression rate is the same, which is 100 to 120 per minute. Mr. Muta, if you can hear me, can you just leave and rejoin? I cannot find the icon to put you on the stage, and it's because your network. So that is the rate. It has to be what? 100 to 120. And for both age, either an adult or a baby, you must have what? That 100 to 120. And that is when you be sure you are doing the right thing. If your compression is less than 100, the compression is less than 100, the perfusion will not be okay. There will be inadequate perfusion when your compression is less than 100. When it's above 100, what will happen is the ventricles will find it difficult to feel. When it's above 100, the ventricle does what? Find it difficult to feel. Please, I'm coming. So when it's above 100, the ventricle find it difficult to feel. I hope you have picked two things now: the depth, the rate. Now, our hand placement is another thing you want to look at. Hand placement must be at the center of the chest. Hand placement must be where? At the center of the chest, at lower half of the sternum. This is our sternum bone. You know that bone now? This is sternal notch. I didn't see you. Please kindly, it's really trying all his best. You are not here, sir. We've been together since almost 3 hours now. We've tested all these things. Only in the night is network we decide not to cooperate again. We are sorry for that. So the hand placement should be where? Lower half of the sternum, and your two hands are interlocking. Two hands are interlocking. Interlocking should be like this. Do we do it like this? No, no. His camera is off. So your camera is off. Check your camera. Your camera is off. Maybe that's why I cannot put you on stage. So it must be at the center of the chest, lower half of the sternum, with our hands interlocking. Do you understand? That's the hand placement. Now, you need to know if one person is rescuing a patient, what is she going to do? That's the compression to breath ratio. Compression to breath ratio. I've talked about depth, I've talked about rate, I've talked about the hand placement. Now, compression to breath. You know, when I say 1, 2, 3, 4, 5, doctor, that is compression. Ah, thank you, Jesus. When I say 1, 2, 3, 4, 5, doctor, that's compression. If you can hear me, you're on stage. You can speak so that we can hear you. You're on stage already. Please speak. Let me know if we can hear you. Oh, thank God. Welcome, sir. Sorry for the stress. We are so sorry for the stress. So here comes the owner of the work for the night.
Oh,
Welcome.
can you see
We're
me,
happy
please?
to have you.
Hello?
Hello, we can hear you, sir. If
Can
you
you see
can
me?
see us, we can hear you. And we can see your stage.
Good. Good evening, everyone.
Good evening,
You are
sir.
welcome to the CPR session. I'm Salis Musa, a BLS instructor registered with American Heart Association. And today we are going to be talking about CPR, how is CPR conducted, and it is going to be a practical demonstration on how to perform CPR. So first of all, what do we understand by the term CPR? CPR simply means cardiopulmonary resuscitation. And when we say resuscitation, we are referring to some techniques, some steps that we take to resuscitate or to bring back someone who is in a life-threatening situation, to save his life. This is what we mean by resuscitation. So when we say CPR means cardiopulmonary resuscitation. This is kind of resuscitation that we give to someone who is having either cardiac or respiratory or both cardiac and respiratory compromise, like cardiac arrest or respiratory arrest or gasping breathing and so on. So now CPR is indicated in cases of cardiopulmonary collapse. Cardiopulmonary collapse means something like cardiac arrest. What is cardiac arrest? Cardiac arrest simply means sudden cessation of heart function, which is characterized by unconsciousness, pulselessness, and breathlessness. These are the three cardinal symptoms of cardiac arrest: unconsciousness, absence of pulse, and the absence of breathing. I hope this is clear. So, if someone's heart stops or someone's breathing ceases, we do conduct cardiopulmonary resuscitation. And this CPR has some stages to follow, the stages that we used to follow if we want to give effective cardiopulmonary resuscitation. let's say, let's assume now we have or we witness that somebody has collapsed. There are many things that can make someone to collapse, whether to have cardiac arrest or pulmonary or respiratory. So once you see someone collapses, the first thing you do is to establish scene safety. Make sure the surrounding is safe for you the resuscitator, you the rescuer. Be safe before you try to help someone. If the scene is unsafe for you or the victim, try to make it safe as much as you can. If not possible, then you can abandon everything and take care of your own case. So the first step during CPR is to establish scene safety. Taking your right, taking your left, make sure everything is okay. There is no any danger to you or to your victim. Then you approach your victim. After approaching your victim, the next step is to take for responsibility. Is my client or my victim responsive? Meaning that is he conscious or unconscious? So you have to take for responsiveness by shouting and tapping the victim. This is what we call tactile and vocal stimulation. You tap the shoulders in adults and child victims, tap hard enough to arouse them. Something like this. Hey, hey, are you okay? Can you hear me? Just two, three tappings of the shoulders is okay. But tap hard enough to arouse them. Okay? If they are conscious, they can hear you, they can respond, then you see them either talking to you or making any sign like moving parts of their body or they make some grimaces or sounds to make sure that you know that they have had this. Okay? You know that they have had you. Good. So now, if you establish that they are not conscious, they cannot hear you, they didn't respond, the next step is to shout for help. You shout for help so that you alert other people around to know that someone's life is at stake. It could be possible you are the only one who noticed that somebody has collapsed. Okay? So after shouting, the next step is to begin to check for pulse and breathing. Now, three types of assessment. We have assessed the scene for safety. We have established that we are safe. We approach the victim and we determine unconsciousness or consciousness. And now he is unconscious. The next step after shouting for help is to check for pulse and breathing at the same time. In adults and children, we take the pulse by carotid artery. We try to feel carotid pulsation by the side of the neck. Two fingers. Use the tip of your fingers by the side of the neck to check for carotid pulsation. Good. You do this for maximum of 10 seconds within time frame of 5 to 10 seconds. Not less than 5 seconds, not more than 10 seconds. This is how you test for pulse and breathing. This hand on the forehead, you try to extend the neck by tilting the head back. This is very important. Simply by doing this, you are opening the airway. You keep it certain. In case your patient has attempts to breathe, he has effort, it will be easier for them to breathe. You displace the tongue so that it doesn't occlude the back of the throat. 5 to 10 seconds, no breathing. Now you give message. We believe that people have now started gathering around. So you look at one of them and give a specific message this time around. You activate emergency response and get AED. You identify someone, maintain eye contact with him, let him or her know that you are speaking to them directly and specifically. Don't give a blind message because blind message is for no one. This one will believe that you are talking to another one, and that one will believe that someone will go for it. And at the end, nobody will respond. So identify one person, make closed loop communication. Use closed loop communication by maintaining eye-to-eye contact. Good. Now, after sending for AED and the activation of emergency response system, now the next step is to commence CPR with chest compression. Remember, we say characteristics of cardiac arrest: no pulse, no breathing, no consciousness. So now our patient is unconscious, without breathing and without pulse. We have sent for emergency response system activation and the AED retrieval. So the next step is to administer chest compression. How do we give chest compression? Chest compression, we have to ensure that we deliver what is called a high quality chest compression. How do we do that? There are elements of high quality chest compression. Number one, make sure that the victim is lying on a hard, flat surface, like a bed frame. If the bed frame is firm, is not having springs that pass, okay, you can do CPR then. Or if you have what we call CPR board, you can get it, then let your patient slide this board under their back to provide the hard surface. Okay. The next element of high quality chest compression is to locate the center of the chest and put the heel of the hand there. Heel of the hand at the center of the chest. Center of the chest in a man is between the two nipples. Between the two nipples, you draw an imaginary intermammary line. Center of that line is the center of the chest. You place the heel of your hand there. Okay? Make sure that you keep your arm straight, no bending. And interlock the fingers. You interlock the fingers with the other hand. Okay? Then you compress the chest hard and fast. Hard and fast. Hard means to the depth of 5 centimeters at least in adults and about 5 centimeters in children. Depth of compression, we say at least 5 centimeters in adults. That means it can go beyond 5 centimeters, maybe 6 or 7 centimeters, but don't go lower than 5 centimeters. In children, at least, or in children, up to 5 centimeters. This 5 centimeters is about 2 inches. Is that clear? So you compress the chest hard and fast. Everything, keep your arm straight, compress hard, just a 5 centimeters, which is equivalent to 2 inches. Then fast means the rate of compressions you deliver per minute should be up to 100 to 110. 100 to 120 compressions per minute. This is what we call hard and fast as element of high quality chest compression. Then another element of high quality chest compression is allowing for complete chest recoil. You know this chest is somehow elastic to some extent. So when you compress, you allow it to regain its normal shape before you compress again. Something like this. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. You go this way. Heart is a hollow muscular organ that contracts to what? Push blood generally in the body for circulation. It pushes blood out when it's contracted. And if it relaxes, it will allow the blood to come back, recollect before it contracts again to send it for general circulation. So you don't compress the chest this way. If you do compressions this way, you are just compressing an empty heart without allowing for ventricular refill. And if there is no refilling in the ventricle, you can never send any blood out to produce effective cardiac output. So decompression an empty heart without effective cardiac output. So always compressions should be rhythmic and sequential. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Okay? So another element of high quality test compressions is minimize interruption. Don't interrupt test compressions once you begin it or someone has begun it. Because once you start giving test compressions, as if you are just building pressure that sustains the circulation of blood throughout the body, especially to the vital organs like the brain. So if you interrupt it, that pressure will crash. And you have to take time before you what initiate it again to send blood to vital organs. So any interruptions decrease the rate or the rate of success of your CPR. Chances of revival or survival is very important when you sustain your compressions without interruption. We only interrupt when necessary. When necessary means when the CPR protocols allow you to interrupt or maybe after delivering 30 set compressions, now you have to pause, then you give two breaths. This is allowed. We don't call it significant interruption. And this interruption is not going to take your time more than 10 seconds. Anything that interrupts you for more than 10 seconds during CPR, try to avoid it because it outcome, low success of resuscitation. If you interrupt CPR, chest compressions especially, the chances of survival is going to be low. So please minimize what interruptions during chest compression. So now there is what we call uh, chain of survival. Chain of survival in CPR means those steps that if you follow them, they what? They maximize the chances of survival for your client. For example, number one, early recognition and the activation of emergency responses. The earlier you recognize that someone is in life-threatening condition, the higher the chances you go and help, and the higher the chances for him to get recovered or revived. So, early recognition and activation of emergency response system, that is what step number one on the chain of survival. Number two is early CPR with emphasis on chest compression. Early CPR with emphasis on chest compression. Why is it with chest compression? In cardiac arrest or during cardiac arrest, the main challenge there is circulation, not breathing. And here we are going to talk about why starting with chest compressions, not breathing. In other emergencies, the principle of resuscitation says follow A, B, C, D up to whatever. But during cardiac arrest, this principle of resuscitation is modified. Instead of ABC, it starts with CABD. We call it CAP D. C means circulation or compression. A, airway, B, breathing, and D in CPR. The D is not for drugs, especially invasive life support. The D is not for disability. The D is for defibrillation. We'll come to talk about defibrillation later during the program. So please always start with chest compressions during CPR because the major challenge there is circulatory collapse. So try to compress the chest so that you squeeze the heart to send the remaining blood there in the ventricle or in the chambers of the heart. Send it to go around the body, especially to the brain. And we believe that initially during cardiac arrest, the blood in our body has some level of oxygen, and that is enough to sustain the cells of the brain. So try to compress the cells, send blood out for circulation to the brain. Brain does not withstand or cannot withstand absence of oxygen supply for more than 4 to 5 minutes. For 5 minutes, no oxygen, the brain cells begin to die irreversibly. So we compress the chest, send blood out of the heart for circulation to the vital organs, especially the brain. Then the next on the chain of survival is rapid defibrillation. Rapid defibrillation, because majority of rhythms, heart rhythms during cardiac arrest are what we call shockable rhythms. Shockable rhythms are abnormal rhythms in cardiac arrest that require use of modified electric shock to convert them to normal coordinated rhythms. And what are these shockable rhythms? We have only two types of shockable rhythms. We have pulseless ventricular tachycardia. Number two is ventricular fibrillation. These are the only two shockable rhythms during cardiac arrest. Then the non-shockable ones, the ones that do not require use of defibrillator or AED, also are two in number. We call them non-shockable. Number one, asystole. If you see a flat line on your monitor, you cannot use defibrillator or an AED to convert it to regular normal rhythm. Or another one is pulseless electrical activity. You see fine ECG tracings, but if you check for pulse, there is no pulse. That's why we call it pulseless electrical activity. And these non-shockable rhythms are usually due to what we call electromechanical dissociation. This is part of the advanced cardiac life support. Maybe one day we should organize a program on advanced cardiac life support. We talk about it. So please, once or immediately you have an AED, automated external defibrillator, use it on a victim who is in cardiac arrest. They say immediate or rapid defibrillation. As soon as you have the defibrillator, use it. About 80% of all cardiac arrest rhythms initially are due to shockable rhythm. So when you have the AED, automated external defibrillator, when you have it, quickly apply it and treat the cardiac arrest. It will help. It will just help and shorten your time so that you don't waste your time or allow your patient to get deteriorate. Good. Then the next on the list is what we call advanced cardiac life support. We activated emergency response system. So the earlier they come and take over from you, the better the chances of survival for this disease. The next is effective post-cardiac arrest care. Effective post-cardiac arrest care is provided in either cath lab, where a patient undergoes series of assessments and investigations to determine the cause of that cardiac arrest and possibly to intervene, like what we call um, percutaneous coronary intervention. Or in ICU, majority, especially in our own situation, these cardiac arrest victims are moved to ICU for more expert management, where many things will be investigated and many steps will be taken to prevent uh, future arrest. Then the last one is what we call recovery phase, where this recovery lasts longer period, longer. Even after discharge, they keep on coming for follow-up and the further periodic assessment. So these are the chain of survival. If you follow them effectively, the outcome for your patient will be very bright. Good. So now let's talk about what we call compression ventilation ratio. How many chest compressions do we give before we give breath? And how do we give the breath? We have demonstrated how we deliver chest compression. So in adults, if you are alone, one ratio, or you are two ratios, or how, no matter your number, if you are resuscitating an adult victim who is in cardiac arrest, you give 30 chest compressions, two breaths. This is the ratio. 30 chest compressions, two breaths. 1, 2, 3, 4, 10, 20, 30. Then you stop and give two breaths if you are alone, one ratio. If you are two ratios, your partner is going to position himself by the head of the victim and be ready to provide breath. Once you say 30, then they will give two breaths within 10 seconds. After the two breaths, you continue giving chest compressions, again 30 chest compressions, then you will give two breaths. 30 chest compressions, two breaths. 30 chest compressions, two breaths times 5. You give 5 cycles of CPR. After 5 cycles of CPR, then you stop and check for pulse and breathing. You do another assessment. Check for pulse and breathing, just like the way you did it before, not more than 10 seconds, to determine whether your client is now breathing or the heart is now back functioning well. If it is functioning, there is pulse, that means the heart is back. So you stop chest compression. If he is breathing, you stop breathing assistance. The assessment can vary. You can either detect there is pulse, there is breathing now. Okay, that is good. This is positive outcome. Or there is pulse, no breathing. This is respiratory arrest. Or there is pulse but gasping. This is also considered no breathing. Please, gasping breathing is considered no breathing because gasping are not normal breathing. The air the client or the victim takes only terminates at the dead stage. It doesn't reach the functional stage of the respiratory system. It doesn't reach the lungs. It terminates around the trachea. So no gaseous exchange is taking place during gasping. There is pause, gasping breathing, there is pause, no breathing. We give what we call rescue breathing. We only assist them with rescue breathing. Okay? There is pause, no breathing. You give rescue breathing. In adults, you give one breath. You count 1, 2, 3, 4, 5 seconds. You give another breath. 1, 2, 3, 4, 5. Breath. 1, 2, 3, 4, 5. Breath. Every 5 to 6 seconds, you give one breath. This is rescue breathing in adults. Somewhat with pulse, but no breathing. You give only rescue breathing. But no breathing, no pulse. This is cardiac arrest. You give CPR. 30 chest compressions, two breaths if you are alone. If you are two in number, 30 chest compressions also, two breaths in adults. So there are many ways to provide breathing assistance. In the hospital, healthcare providers, we use this BVM, bag, valve, mask device, BVM or ambu bag, whatever you call it, or ventilation bag. This is the complete set. If you have it this way, this is oxygen tubing. You connect to oxygen source, whether wall pipe oxygen source or oxygen cylinder or maybe oxygen concentrator at high flow, above 10, okay, like 12 to 15 liters. This is reservoir bag. It gets inflated if you connect this to oxygen source. So you store oxygen so that whenever you are giving breath to a patient, it will be highly rich with oxygen. You give a kind of FiO2 of about 90 to 100 if you use it this way. If you don't have oxygen source, you detach all this. You remove them. Unfortunately, this one cannot be detached. It is just made in such a way that we use it this way. So there are ones that are detachable. You detach this unit and use the back plain without this attachment. Okay? By doing so, at least you give room air 21%, which is enough to resuscitate your patient. If it is out of the hospital or out of station, you can use what we call pocket mask. This is what we call pocket mask. Okay? How do we use a pocket mask to provide breath assistance? This is how it looks like. You just push it up. It has a one-way valve that allows air to go in only. Doesn't allow air from the client to come back to you. So it has some broad end and the sharp end. Always the sharp end is guided on the nasal bridge. So this is how you do. After 30 circumferences, you can use this one to provide two breaths. You tilt the head back using this hand. Okay, I hope we can see clearly. Okay, this is how you hold it. So you tilt the head back. You extend the neck so that you keep the airway perfectly. Then you use this hand, these fingers, to pinch the lower part of the mask against the skin to maintain what we call airtight seal. Then you blow in air with volume that is enough to cause chest rise. One, two. Then you continue chest compression. 1, 2, 3, 10, 20, 30. You come again and give one, two. Each breath is given over 1 second. Don't prolong time for giving the breath. Over 1 second, you give one breath. I hope that is clear. Good. So now this is breath assistance. Sometimes you may need to give what uh, we call it mouth to mouth.
expecting him back. I hope it's been a wonderful session so far. I think he lost network. It's not on this call for now. So we'll definitely rejoin. But while we are waiting to have him back, have we learned anything new? I hope NCLEX keys have not wasted our time. Of all the CPRs I've taught so far, now this is practical. I mean, NCLEX focused practical. So let me hear your feedback in the comment section. Are you enjoying the class? Any question you can ask before you join us again. I've sent him the link. So let me hear you. How has it been at your side? Any new knowledge added? Can you hear me? I'm sure you didn't lost me. Am I right beside you? Can you hear my voice? Ah. Oh, welcome back. So he's back. Welcome back, sir. Okay. So if you can see us, kindly keep on. Keep talking, sir. You are here.
Good. Thank you. So another technique or method of providing breath assistance is what we call mouth to mouth or keys of life.
We can't see you on the stage yet. I think the network.
But
Can
I
you
can
see
see
him
you
on the
now.
stage? I can't see him from here. You can see me, but me, I can't see. But let's wait. Can people see you? Please, can he see him? Can you see him on the stage? It might be my own network. Can you
Confirm
see
from
him?
them.
If you can see him, then let him continue.
Can they see me?
Can you see him on your stage, on your screen?
They're responding.
He said, "We can't see." They said no, they cannot see you. Please kindly leave and rejoin.
Okay.
They can't see you. They can't see you. Please leave, sir, and rejoin. Sorry for the stress.
No problem.
Sorry for the inconvenience, everyone. We will rejoin, then we can see his workshop. So while we're waiting for him to rejoin, Nurse Daniel, tell me 2 things you have learned in this class. Just type it in the comment section or on your WhatsApp page. 2 things you've learned so far in the class that are new to you. You know, this is not about BLS alone. It's about
Hello?
an NCLEX
Someone
tutor
hear me?
teaching BLS. Okay.
Good.
We can actually hear you, just that we cannot see your workshop. You have joined with 2 devices now, and none is showing your face. Okay, this should.
Me?
None is showing your face.
Is it me?
I can see the 2 devices, but none is showing your face, and your camera is actually on. So compression should go deep from 5 cm. Yes. What else again? What else did you learn? You know, I've always read interlocking, but today I learned that this is the interlocking. If you notice, when I was trying to talk about this, I said this is interlocking. Did they do it like this? But today I learned. Oh my God, Mr. Mokta, we can't see you.
Let me log out.
And we can't see you. I can't see him, and his camera is on. I think it's just his network. So, you know, when I was talking about it, you see me doing it, because we have always placed it in my own 26 years of nursing practice. I don't think I've done CPR 2 times. I must hand over that patient alive, whether by prayer or by whatever force. So I don't know how to do CPR. Aside from the fact that I read it in the book, I can teach theory, but practical, no, I don't. I must be sincere with you. And if you notice, you see me doing like this. Do they do that hand like this? I know it must be interlocking, but how? But today I learned the interlocking. That is, sure you can see my finger. His own was a bit dark. The interlocking is like this. And use your heel the more. Is that heel, this place, the heel of the palm that can give the depth that we want, you know. Now I'm doing it better, unlike when I was doing it like this. So I told us that, okay, you were laughing when I don't know how to do it, I'm not lying. After compression, allow for a recall. Also during ample bagging, do not hyper compress, allow for a recall. That's beautiful. Can somebody else type what he or she has learned in this class today? I've told you. Nurse Monica, and you didn't tell me that I was not doing it. I know I was not. I said, do they interlocking? Do they do like this? I don't know how to do CPR, but I've learned a lot in this class, honestly. But I don't want to practice it. Because by the time I hand over and come back and they are telling me how it feels like to do CPR, sometimes they say the doctor fling away his lab coats, the nurse do this one. I don't want to witness it. So, but it's actually what we need to know. And I'm happy that I'm part of this class tonight because I now know it is 30. Then in the past, there is this knowledge in the past that when you are 2, you give 15 to 2. Now, either you are 1 is back, or you are 2, you must give 30 to 2. I learned about how to use the pocket mask. Oh, you don't know it before. Nurse Mokta, we cannot see you, and we are enjoying that class.
I'm seeing you, ma. You don't see me?
No, it's not about you seeing us. It's about we being able to see you and what you have to show us.
Oh my God!
I'm not sure anyone can see you. So please keep it coming. What else have you learned in this class tonight? While I try to, then it's noisy. Keep it coming. What else have you learned tonight? While I try to emphasize 1 or 2 things. So in the past, it used to be 2 people, you give 15 to 2. That's the common knowledge many people have. Am I the only person that I've heard about that before? But the current practice, whether you were 2 or you were 1, it is what? 30 to 2. Don't forget. He hasn't gotten to the children or infant home. That one is 15 to 2. I know theory very well. I mean, I don't know how to practicalize it. For infants or children, theirs is 15 to 2, like 1, 2, 3, 4, 5, 6, 8, 10, 12, 15. 2 breaths. Another thing is, you see that mask, that ambu bag, you must make it to be tight. You must use the mask that size the patient. If that your mask is not the patient size, what will happen is that your rescue breaths will just thank God, it should be better now. Your rescue breath will just be wasting. It will not go to the airway. Then, okay, I've added you, sir. If you can see us. Okay. Maybe you just make the related theory for us. We can't see your workshop. And it's so noisy at your end. Very noisy. You're on the
Hello?
stage, sir. You are. We can hear you, but we cannot see you.
But
Maybe
I have
you
some,
just try and make the related theory for us.
lots of echo.
We can hear you. Continue. We can
Can
hear
you
you,
see
sir.
me?
He's asking, can you see him? Please, everybody, can you see him? Maybe it's my network. Can you see him? Can you respond if you can see him? No, they can't see you, sir. You can keep talking. Let's not take a lot of time. Just keep talking. Hello, sir. What's the amount of hair you push in with the ambu bag? Amount of hair. Okay. Is there anything like amount of hair to push in? Coach Salisu, what's the amount of hair you push in within the ambu bag? This network, it's really messed this thing up. Okay, let me continue my highlights now. Oh my God, seeing 2 devices. You can't see any one of it. Okay, let him come back to answer the amount of hair you push in. I don't think I've ever heard about that before. The only thing is you don't want to be, you don't want, according to what he said, you don't want to compress it too deep. But the amount of hair, I don't know. I've not heard about it before. Okay. I've not heard about it before. Now, he was explaining something about 5 to 1. I lost him at that time. I really wish to ask him to explain back what he said about 5 to 1. I think he was talking about rescue breath. Okay. Now, the difference between rescue breath and CPR is you give rescue breath to someone that is not breathing properly. I've added you, sir, if you can hear us.
I
You
can
give
hear you.
breath, but we can't see you. Please continue, sir. Let's entertain our questions. Okay, they say you should log in and log out.
Okay, let me
Mr.
ask you a
Musa,
question.
can you leave the stage completely and use the link to rejoin? We might be lucky. Or you close your YouTube completely. Or close the YouTube completely and reopen, please. We want to have it finished. Sorry, sir. Okay, so rescue breath is that is a way of assisting someone that is not breathing properly. While the CPR itself is someone that is not breathing at all. He said that the brain cannot stay for more than 4 to 5 minutes without oxygen. What will take oxygen to the brain is blood. Who will push the blood to the brain to supply oxygen is the heart. This same heart, for now, is not responding. So we have to find a means to do what? To make this heart respond. Now, sometimes somebody has a pulse. Somebody have a pulse, but is not breathing normally. Somebody has, you check, there's pulse. Maybe the pulse is 45, 47, but you could see that that breathing is not making sense. That breathing is not the type of breathing you want. So at that time, what you do is you give a rescue breath. Welcome back, sir. We still can't see you. Please attend to our questions and let's end it tonight. We still can't
Okay.
see you, sir. Okay, so I have some questions here. First off, we want to appreciate you, but you haven't talked about infant CPR. Can you quickly run on that? Infant CPR. Hello, sir. He's out of the call again. Okay, so I was trying to talk about that rescue breath. That is when
Okay, do you hear me now?
we can hear you. Can you quickly talk about infant CPR? How to do CPR for an infant? Please, sir, hold on, sir. Please hold on, sir. When do you do first chest push? This one they do like this. You understand? Why do you do that? When do you do CPR? The head positioning. I hear you talk about being on a rigid surface. That's perfect. But when do you use jaw thrust, chin lift? These are things we want you to emphasize now. Thank you, sir.
Okay, thank you. So let me start with the positioning, okay, of air or airway opening maneuvers. We have what we call head tilt, chin lift, just the way I demonstrated on others, the way you tilt the head back, you keep the neck extended, and you put your fingers on the chin to lift it up. This is for someone with normal cervical spine. But if you suspect any cervical injury, maybe a victim of accident, whether it is obvious or suspected, so you don't do head tilt, chin lift. Instead, you stabilize the cervical spine and you do jaw thrust. Jaw thrust. If you suspect any cervical injury, please don't do head tilt, chin lift maneuver. Use jaw thrust maneuver. Is that understood? Then regarding CPR on infants, I just started with adults and I was about to come to children, then infants. Infants are a special age group and the resuscitation or CPR on them is also different. We know infants they are from 28 days to 1 year. Anyone in this
Yes.
age range is called an infant. So in them, the technique of compression is different. In the old guidelines, CPR guidelines by American Heart Association, if you are alone, we use two-finger compression technique. But now with the current review, 2025 guidelines, they have abolished use of two fingers at the center of the chest if you are a warrior on infant resuscitation. Now you use your what? As you are doing compressions on others, you put your palm or your heel of the hand at the
Wow.
center of the chest. This is the
No
new
more two
CPR guide.
fingers.
No more two fingers. The new
Wow.
2025 American Heart Association guideline is you use one hand compression technique. You put the palm of your hand or the heel of your hand at the center of their chest and you use reasonable force to compress their chest. Please be careful in compressing their chest so that you don't see their lungs through the mouth. So just use reasonable force. Okay? But if you are two in number, okay, you use what we call two terms in cycling hand technique to compress the
Please come
space
again.
of a two terms in cycling hand technique. This is if you are
Okay.
two rescuers resuscitating an infant. And with respect to compression ventilation ratio, if you are one rescue also in a child CPR or infant CPR or adult CPR, the compression ventilation ratio is it remains 30 chest compressions to breath. All scenarios of wire rescue, please, whether in adult, child, or infant, compression ventilation ratio remains 30 chest compressions to breath. Is that clear? Then in children and the infant, if you are to rescue, compression ventilation ratio is 15 chest compressions to breath. 15 chest compressions to breath if you are to rescue in a child or infant CPR. Because children, infants, they require high or they have high respiratory rate than adults because of the high metabolic activity. So we need to give them more breath, more oxygen, because metabolism requires oxygen as a fuel. So give them more oxygen. That's why we cut down the number of compressions we give them so that we maximize number of breaths. In infants, we said if you are alone, you use one hand to compress their chest. If you are two, you use two thumbs in cycling hand technique to compress their chest. What you do there is to put your two fingers at the center of the chest of the infant. The center of the chest is just that you place these two fingers these two thumbs side by side, just below the nipple line, at the middle of the chest, just below the nipple line. Then your remaining fingers will encircle the chest of the child. You give support as if you are supporting their back with the remaining fingers, as if you want to carry them. Okay? This is how you hold them. Then in children, we still use our what? Heel of the hand at the center of the chest. The only difference here is that the depth of compression in children we say about 5 centimeters. Okay, so don't go beyond 5 centimeters, please, so that you don't cause injury. Okay,
That's for
in
infants.
infants, the depth of compression is 4 centimeters. Depth of compression in infant, 4 centimeters, please. Okay.
And that's how many inches, sir?
Please, can you come back again?
4 centimeters is how many inches, sir?
Hello, ma.
4 centimeters is how many inches, sir?
Sorry.
Okay. Continue, sir. Continue. Go on.
Do you hear me now, please?
Go on.
Do
Continue,
you hear
sir.
me? Good. So, please, in children, depending on the size of the child, you can decide to use one hand. If you think the size of the child is small
and one hand is enough to compress their chest up to 5 centimeters in children. But if the child is big like me, you use 2 hands to compress the center of the chest. What we require generally is to deliver 100 to 120 compressions per minute. That is the rate of compressions. Why are we emphasizing on this is that there are situations whereby somebody cannot provide 2 breaths within 10 seconds, or maybe he doesn't have all these pocket mask or ventilation bag, and he cannot use or he cannot share his mouth with someone else. So in such situation, it is encouraged that we give what is called compressions only CPR. And in compressions only CPR, we target 100 to 120 chest compressions per minute. Is that clear?
So we will not give rescue breaths in that situation.
Yes, if someone for any reason cannot provide breath, just
How do I know
continue
if
to.
the patient cannot provide breath, sir?
No, the rescue cannot provide breath. Either he doesn't have equipment, or he fears infection by sharing his mouth directly with someone in case of mouth-to-mouth breathing, because naturally some of us cannot provide or give mouth-to-mouth unconditionally.
Okay.
You understand? But maybe people like me, I can just go ahead and give mouth-to-mouth unconditionally. Or if you fear attack, maybe especially in the case of opposite gender, maybe let's say a woman brought her husband, is in cardiac arrest, and you didn't explain to her, then he needs breath assistance. You just go ahead and start kissing him. She doesn't understand the meaning of, this kiss of life.
Providing the breath.
She may say, see this woman now kissing my husband. Or see this man kissing my wife. So if you fear this kind of misunderstanding, just continue to provide what is called compressions only CPR. Or if you fear
Okay.
contracting infections, especially
Okay.
with this uh, beginning of COVID up to now, they have now relaxed on this mouth to mouth. They say if you feel you can give, you give, but no one is forcing you to give mouth to mouth. But at least it's something that we can give to our close associates, like family members. Okay, people that we care about most. You can at least give them mouth to mouth. And you can use other barriers, okay, to protect yourself. Handkerchief or some baby wipes or anything that can serve as a barrier between your mouth and that of the victim, so that you
Okay.
protect yourself. So what else is the question again?
Okay. Somebody was asking that even in a newborn, do you use
Yeah.
the palm instead of the 2 fingers? Even in newborn?
Okay, listen. When we say BLS only covers resuscitation or CPR in adults, child, and infants.
Okay.
We don't talk about neonatal resuscitation. It's an
Wow.
independent resuscitation program on its own. That's why in
Wow.
BLS it is not mentioned there. Okay? Neonatal resuscitation is an independent resuscitation of its own.
So if a child is not 28 days, BLS does not concern him or her.
Yes, you give neonatal resuscitation.
Wow. That's nice.
You treat them as neonates.
Okay. So there's another question here, sir.
Okay.
At what level of pulse should you start CPR? Like
Okay.
there are some situations when patient will have pulse and you still have to maybe start CPR or give rescue breath. At what level of pulse
Good. Especially in children or infants, the rule is that if the child or the infant is having pulse less than 60 per minute, despite
60.
at 60, 60, if the pulse rate is less than 60 per minute despite adequate oxygenation, you start
Okay.
CPR, especially in infants. Meaning
Infants
that,
and children.
yes, meaning that they are on oxygen therapy, adequate flow of oxygen therapy, but the heart rate is less than 60 with signs of poor tissue perfusion. You start CPR, they are in cardiac arrest.
Okay.
Yeah,
What
but
of adults?
in adults, you have to do further assessments, determine that
Okay.
they don't have pulse at all. Okay, because pulse less than 60 in adult, we can wait and start maybe giving atropine or fluids or something like that, or simply give oxygen to improve the coronary perfusion. But in children, if they are on oxygen, their pulse is less than 60, with signs of maybe cyanosis, you start CPR.
So if an adult has pulse of 40, 38, 35, and all these symptoms you are talking about is being seen, can we also start CPR?
Symptoms of poor tissue perfusion, loss of consciousness, and gasping. Okay?
Yeah.
If the breathing pattern is gasping respiration and with low pulse like this, you get ready for CPR. But if it is something that can be corrected, for example, there is hypovolemia, you can correct, or you use atropine, some agents to boost the heart rate, you can do that. But just be ready for resuscitation because your patient is unavoidably going into cardiac arrest. Okay? So just be ready. If you don't have all these fluids, you don't have the inotropes to start, please start CPR. Call for help. Always, if you are commencing CPR, ensure you call for help because this is very tiring task. You can't do it alone effectively. So you need people to come to your rescue also to help you. Good. Any other question?
I have a question here that I want to post on the WhatsApp page.
Okay, man.
So I would want everyone to go there and attempt it. Just attempt it. Let's see whether we understood all he's been saying since. This is not for you, our lecturer, sir. This is
Let
for
me
us.
let me talk about what you were asking. I now remember. You were asking about something like abdominal thrust.
Okay, yeah, I asked.
This is the intervention we give for someone who is experiencing choking, usually adults or child who is responsive. Because in choking, we have responsive victim and we have unresponsive victim. So we treat these under what we call special considerations. Special considerations are conditions that, if not given prompt attention, can degenerate to cardiac arrest. So choking is part of them. Choking simply means either partial or complete obstruction of the airway by a foreign body. Okay? If the airway is obstructed, somebody cannot breathe, somebody cannot cough, and somebody cannot speak. This is choking. Maybe they are eating, making noise, they are eating and making noise. So the food particles can now misroute and go into the trachea and block it. So If they are conscious, they can obey command. Let's say it's an adult. I just wish the video can show my this. The camera can show me. You come to them
Oh,
and ask them simply, because you have to see what we call universal sign of choking. All
you can
choking
help us
victims.
make the recording, sir, if you don't mind. We really
Okay.
need it.
Universal sign of choking. Anyone choking, whether in Nigeria, in America, Saudi Arabia, in England, wherever they are in the world, they do present with one posture. We call it universal sign of choking. They put their hands on their neck as if they want to arrest something on their neck. Both hands,
Is
ma.
it like
Both,
this?
both hands. Put your both hands.
Like this?
Good. Yes, ma. Exactly. This is what we call universal signs of choking. You see their eyes out in distress, looking for help, mouth open. So we just quickly approach them and ask, are you choking? What do you expect them to say?
Oh, 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 oh.
Of course, they cannot talk. But if they say, yes, I'm choking, no, they are not choking. Maybe they aspirated. So you encourage them to cough and cough and cough so that they clear the airway. But because the airway is completely blocked, no air movement in and out, so they cannot produce any speech. The highest they do is to nod their head to confirm to you that yes, they are choking. They only nod. So once you see that, you reassure them, please keep calm, I'm going to help you. You come behind them, ask them to open their legs. You carry one of your legs in between their two legs, make body contact with them. Then you put one hand, okay, toward their, what do you call this? Umbilicus, okay? You make a fist with your dominant,
Umbilicus.
yes, make a fist with your dominant hand and carry the thumb side of your fist. Just place it above the umbilical. Then they use the other hand to support this fist. Then you'll be pressing inward, upward quickly against the abdomen. Inward, upward quickly. This is what we call abdominal thrust or Emlich maneuver. Okay? You
Emlich
do this.
maneuver.
Emlich maneuver or abdominal thrust is all the same. You do this like 5 times, then you give them back blow with your palm of the hand. 1, 2, 3, 4, 5. Then you continue the Emlich maneuver until the object is out. This is what we are hoping, the object to come out. If it fails to come out within maybe 2, 3, 4 minutes, then he will lose consciousness, go into cardiac arrest, then you feel his weight on you because you are supporting him. Once you hear that, when you feel that his weight is more on you, the hands are down, that means he has lost consciousness. He is now in cardiac arrest. You now carefully lie him on the floor, activate emergency response system, and start CPR. You do CPR with one exception. After 30 chest compressions, before you give the breath, quickly open the mouth and see if the object is nearby. You can see it.
Okay.
Carefully remove it. If you don't see it or it's too deep, don't try what we call blind finger sweep. Don't do that.
Okay.
Just go ahead, give the breath, and continue your chest compressions. Anytime you come to give the breath, try to check them out. If the object is nearby, you remove it. If not, go ahead, give the breath no matter what. Are we clear? This is for adult or child victim of choking who is responsive. For the unresponsive one, this is what we do, CPR, because they are in cardiac arrest. CPR. But we may have a choking victim, maybe a pregnant woman or a pregnant man. Okay. If a man with big belly, you cannot go around his belly. So you go to the chest, apply what we call chest thrust. Okay? Press on the
Okay.
chest, just like the way you press on the abdomen, press on the chest. It
Like
will yield.
this?
Use your all hands to put your hands round the chest
Okay,
and
round the person's chest.
yes, and be pressing, be squeezing. Okay? That will be increasing intrathoracic pressure, will be compressing the lungs. And if the lungs are compressed, they expel air out along with the obstructing object. This is the logic. Then for infants, the intervention is different. If they are responsive infants experiencing choking, you carry them on your arm with face down. Maybe if I get time, I will do the video and send to you so that you
Please
share
try and
it.
get the time, sir. We are waiting.
Yeah, so that you share it on the group. For infants, you hold them on your arm, face down, you hit between their two shoulder blades, use your heel of the hand, you just strike that space between the two shoulder blades. We call
Like
it
that
back.
space between the two scapula. You just do
Yes,
like
ma.
this. Abi?
You give what we call 5 back slaps. 5 back slaps, then you turn them on the other hand, face up. Now you give 5 chest thrusts. Same
Wow.
position,
That's like chest first.
yes, same position that you deliver chest compressions using 2 fingers in infant. You remember the old pattern of giving chest compressions. So you give chest thrust. But the way you are holding the baby, you make sure that there is what we call head down position. We want gravity to assist to push the object out. Okay, so slightly keep the head of the baby down while giving the slaps and the chest thrust. If they are become non responsive, then you activate emergency response system and start CPR. Like we describe it in adults, after chest compressions, before you give the breath, always check them out. If the object is nearby, you can remove it. If not, don't look for it. Go ahead and give the breath. That's understood.
So in this situation, do you also give rescue breath or there is no need?
You still give
In this
because
situation, do you still give rescue breath or there is no need?
which situation, responsive or unresponsive choking?
Unresponsive, responsive, both of them.
Irresponsive because they are still conscious, you don't give breath. You just try to quickly dislodge the obstructing objects. But
Okay.
in unresponsive one means that they are in cardiac arrest. Remember, they have not been breathing. It has taken them time not breathing. So now the heart itself will get tired because it is not getting oxygenation. Oxygen is not going to the heart. It will get tired and stop. Once it stops, that means they're in cardiac arrest. So no breathing, no consciousness, no pulse. This is cardiac arrest. You give full scale CPR. With only that exception, before you give the breath, open the mouth, check. If the object is there nearby, you remove it. If not, go ahead and give the breath. Good.
Thank you so much, sir. There's a question on your WhatsApp page. Can you attend to that?
My WhatsApp page.
Yes, sir. Are you close to your phone? Or you want me to read it out?
Let me see. Okay.
Is someone's comments? Why you? Maybe I should just talk about it.
The issue
Can you
of
hear me, sir?
if the of consciousness, number 2, absence, number 3, absence of pulse. So if the pulse is present and
No,
is
sir.
sufficient, you don't compress.
It's on your page, your personal WhatsApp. Let me talk about it. The person commented that you never start a chest compression when there is a pause. I said, is this always true?
I mentioned in
I've lost him again. Can you hear us? Hello, sir.
I can hear you, ma.
Okay, sir. I said, is this always true that you don't start chest compression when there is a pause? Note the word always.
It's not always. Why? Because I mentioned the situation or the exception in infants. I said in infants, even if they have pulse, but it's less than 60 cycles per minute, despite adequate oxygenation, you start CPR. So you can see it's not always.
So the person that comments, please, you can hear that. It's not never. The word never is what I want to bring out. So if you also use that word never or it use the word always, no, that is not right.
Only what
Okay.
you do, you read your questions. If it is in exam questions, read the background information. Okay, the pulse. What is the quality of the pulse? What is the rate of the pulse? And under which circumstance? Is it in infants? Are they on oxygen? The pulse also less than 60? You have to take note of this.
There is another thing I want to add, sir.
Yes, ma'am.
You can also start a CPR when in 10 seconds you cannot feel a pulse in a patient that is really feeling sick. If you can't feel my pulse in 10 seconds, you can't start CPR for me. I'm standing, I'm sitting, talking to you. You can see I'm fine.
Okay.
But in a sick patient, especially when breathing is bad and you're looking for pulse, 10 seconds, you cannot find it. That may be a candidate for CPR too.
Excellent. Even among healthcare providers, sometimes taking for pulse is very challenging, especially when conditions are not good. Maybe someone is in shock, you cannot easily detect their pulse. So that's why they give this time range. Okay? If
10
within 10
seconds.
seconds you cannot detect pulse, just consider them in cardiac arrest and start CPR. They are not conscious, they are not breathing or gasping, and you cannot feel pulse within 10 seconds, just start CPR.
So have
That's
you
why
seen
if
that the word never is not correct, please?
never is not always correct. Okay? So that's why if we are training heart savers, those who are not healthcare providers, we don't insist on checking for pulse. Let them just know how to identify this one is unconscious and he is not breathing. That's all. Good.
This has been so wonderful. Any other question before I release my
Let me
my
just
wonderful brother?
let me
Okay,
just give them one bonus regarding causes of cardiac
please
arrest.
go ahead, sir.
We only pay attention to what we call reversible causes of cardiac arrest. There are many causes of cardiac arrest, but when it comes to CPR or resuscitation, we pay much attention to the reversible causes of cardiac arrest. And these reversible causes are simply categorized into two. We have what we call H causes, H, letter H. We have
Six
T
age.
courses. Yes, letter T. T
Six
courses.
age 6.
Yes. The H courses, something like hypovolemia, hypo or hyperkalemia, hypothermia, hypoxia, and hydrogen ion disturbances, that is acidosis. These are the H causes, H reversible causes of cardiac arrest. Then the T causes or T reversible causes of cardiac arrest, they include number one, toxins. Toxins, when we say toxins, including sepsis or drugs, okay, that can keep the heart down or shut it up. Then we have tamponade, like cardiac tamponade. Then we have thrombosis, thrombosis pulmonary. Another thrombosis, thrombosis coronary. Then we have tension pneumothorax. These are what we call reversible causes of cardiac arrest. Meaning that if you are dealing with cardiac arrest victim, try to be checking for these reversible causes while you are resuscitating him, and at the same time correct them. He is hypovolemic, try to secure IV access or IO, start fluids. He is hypoxic, give oxygen. He is hypothermic, provide warmth. Okay? If there is any potassium issues, try to correct it. Hypo or hyperkalemia. Are we clear about this?
Yes, sir.
So, any other question?
Any other question? Don't worry, I'm trying to type the H and T courses. I think they are 6 each. So I'm putting it on our WhatsApp page presently. So, in the absence of no other questions, how many people enjoyed the class? If you enjoyed the class, send big God bless you to Nurse Mokhtar, all the way from Aminu Kano University. Please send big God bless you to him. If you have gained something, if you have enjoyed the class, in your comments, I need you to just send big God bless you to him. So, Nurse Mokhtar, can you help us with the question on the page? I hope everybody got it right. 1, 2, 3, 4, 5. What is the system? Hydrogen ion. I hope everybody got it right. See now, they are greeting you. God bless you, sir. NCLEX KEYS love you. We love you. We'll still invite you again very soon. Thank you so much. Thank you. I want to appreciate everyone. Thank you for joining. Thank you for waiting to learn. I hope it's a lot better. Very soon we are bringing our class to video. At least for those who learn with visual. Very soon we are. For some of us that have joined our video before, you can see this is a lot of improvements. Give NCLEX KEYS, God bless you too now. And I believe that whichever way question comes from this CPR unconsciousness, we will get it. I believe. So in the light of it, by the grace of God, before tomorrow evening, I'm going to put 50 questions on this on our platform. So kindly go there and ensure you assess it. Thank you, ma. We appreciate you. So thank you, thank you, thank you. God bless you. Till we come your way again on this platform, enjoy your night and know that you shall come rejoicing, bringing in the past. Yes, bringing in the past, bringing in the past. By the grace of Almighty, you will bring in the past. so shall it be.
Amen.
Congratulations.
Amen.
We love you. Bye-bye.
Thank you so much. Bye bye.
Thank you so much, Nasmukta. Bye for now, sir.